Given that this is an Ignite talk and it's very brief, I'm gonna try and give you a brief overview of like sort of my thoughts on engagement and early psychosis care. And that's why I've titled this like a snapshot of the psychosis continuum, because I could probably talk about this for hours naturally, but I'm gonna try and be very brief, which is a tricky thing, I guess, for a researcher. So yeah, let's just kind of jump right into it. So for me, I think I like to sort of think about disparities work in general, not just through the lens of like research, but also from voices of people who have like actually have experiences navigating mental health care systems. And so when I think about this, one really sort of good book that actually has a really interesting intersection with psychosis and race is this book, When They Call You a Terrorist, by the founders of the Black Lives Matter movement. And so, interestingly enough, one of the founders, Patrice Khan-Colors, had a brother who was diagnosed with a psychotic disorder. And so, for him, what would happen is that they would have this sort of chronic cycle of like him having a psychotic episode or symptoms sort of worsening and having to call the police because they were really concerned about his safety and things like that. But what she noticed was that her brother was treated differently when they even made these mental health calls, right? So oftentimes he experienced sort of trauma at the hands of police despite being diagnosed with psychiatric illness or having symptoms of psychosis. And so this is actually what sort of catalyzed her interest in starting the Black Lives Matter movement, seeing that even for someone who has a diagnosis of a severe mental illness, like he was still being treated very poorly by the police. So it's interesting because I think when we think about the Black Lives Matter movement, we think about police brutality, but we don't think about it through this lens of mental health, which is an actually really interesting intersection here. And so her brother also later on developed PTSD and became really fearful of the police as a result of these encounters. So it's an important context because I think this experience is not abnormal, right? It's not a sort of one-off thing. I think we can talk about many folks who have experienced really traumatic or aversive pathways to care in their engagement with the mental health care system, even regardless of like psychosis or other severe mental illness diagnoses. So another sort of book that's really useful here to sort of think about the sort of intersection between race and psychosis in particular is this book called The Protest Psychosis, which I think a lot of people reference when they're talking about sort of psychosis and race. And so this book is really useful because it really traces, John Metzl really does this really good job of sort of doing this sort of research on this sort of the psychiatric hospital and how their client population shifted over time from being predominantly sort of upper middle class white population to shifting more towards African American men in particular during the sort of civil rights movement. And so this book really focuses on this idea of like the pathologization of Black rage, essentially, and how certain pharmaceutical drugs are sort of marketed towards Black rage in particular. And that's kind of like, again, I don't have a lot of time. I could talk about this book for a while, but this book is a really useful sort of case study in sort of how race and certain features associated with certain racial groups can often be pathologized and lead to misdiagnosis and things like that. And so a particularly good example of this from the book is this early sort of ad of Haldol, right? A common antipsychotic drug used at the time. It's a little blurry because it's an very old ad that I found online. But what you can see is that there's this image kind of a Black man in like this sort of 1970s sort of garb. And it says assaultive and belligerent. Cooperation often begins with Haldol, right? And so you can see how if we talk about sort of how people of color are viewed in general by mental health care systems and the prescriptions that they are often given, how this is kind of like how the pharmaceutical companies sort of like essentially marketed these drugs towards certain groups of people. And this is something that I bring up not just to talk about the historical context, but because oftentimes even today, Black clients in particular are more often prescribed first generation antipsychotics that are associated with aggression or things like that. And on the other hand, you can also think about this as thinking about sort of barriers to folks engaging in care when people of color have often felt like they've been pathologized or viewed as aggressive or hostile by mental health care systems. They're going to be less likely to engage with those said systems. So it's an interesting sort of case example of the sort of bidirectional relationship between how historically folks have been treated and influencing how people engage in treatment today. So that's kind of like this sort of brief historical context in a nutshell. But I think just to kind of highlight some of these sort of long-standing effects of historical racism, you can look at certain things in terms of diagnosis rates and sort of how Black and Latinx or Black BIPOC clients are perceived within the mental health care system, particularly around psychosis, right? And so in general, what we have is a sort of a higher rate of diagnosis of psychotic disorders for Black and Latinx clients. In fact, meta-analyses show that Black and Latinx clients are about 3 to 4 times more likely to be diagnosed with a psychotic disorder, particularly schizophrenia. Also, there's some interesting studies really looking at sort of clinician perception of clients of color. So for example, this study by Beshaun and his colleagues from 2014 shows that clients of color are more likely to be perceived as dishonest and underreporting their symptoms. And so on one hand, you could say, okay, maybe there's some signal here, right? Perhaps clients of color are underreporting symptoms for the reasons that I just disclosed, right? Being this sort of fear of being viewed in a certain way or have a label being put on them. Alternatively, it's interesting to think about how we as mental health care providers and researchers assess folks of color, right? Like, what are we, like, how are we viewing them, and how are our own diagnostic biases playing out into that as well? And so these sort of decisions in terms of diagnosis and sort of treatment course have consequences, because there's a lot of research showing that clients of color are hospitalized at higher rates and have longer hospital stays than white clients in general. So this is all I think this is all a very important context as we view some of these disparities in sort of engagement with care and subsequent outcomes, because we're seeing that, like, even sort of from the start, there's already a disparity that starts to emerge. And so, like I said, we could talk about sort of various sort of focus areas in sort of early psychosis care, such as the pathways to care, sort of how people get to the clinic, sort of the first episode of psychosis, and then these long-term outcomes. But for the sake of time, because we have 10 minutes, probably about 7 or so now, maybe less, we're just going to focus on pathways to care in first episode psychosis. And so there's a lot of data points here that I'm going to sort of talk about. But in general, one thing that we talk about with early psychosis intervention in particular is this idea of the duration of untreated psychosis. And so essentially what this is the period of time in which people have a psychotic disorder but are not engaged in treatment, right? So the idea here is that a longer duration of untreated psychosis is associated with worse outcome due to, you know, the symptoms worsening and the sort of neurological sort of impact of psychotic disorders as well. But there's this sort of strange paradox that kind of exists in literature where a lot of meta-analyses of duration of untreated psychosis suggest that Black Americans have similar duration of untreated psychosis as white Americans, but they remain at increased risk for poor outcomes, right? So you would think that because, you know, we target DUP as like one of our main things, getting people into the clinic sooner with the idea that they'd have a better outcome. But even though we're seeing similar duration of untreated psychosis, other things are going on that are leading to worse outcomes for Black clients in particular than white clients. And so this is where pathways to care sort of come in, right? So there is a lot of literature suggesting that the sort of how people get to the clinic in general differs by race, right? So for example, there's some research that suggests that Black clients in particular are more likely to engage in treatment through more involuntary or caustic means. So with police involvement or when symptoms are at their worst, or through like civil commitment and things of that nature. And so we could see this as like, on one hand, people are getting engaged with treatment, right? But on the other hand, if there's not much agency or much choice, how likely are you going to be engaged in treatment long-term, right? If I'm being forced to go to a treatment because of a court order, if I've been like arrested or I'm afraid of being arrested, I might not engage in treatment as meaningfully because of this sort of like coercive nature of care. Another sort of difference in the sort of pathway to care is that for white clients, oftentimes there's more of a likelihood of being referred from like a primary care doctor or a specialty clinic or other mental health care provider. Whereas for Black and Asian American clients, it's more likely to be the sort of emergency room route that I just talked about before. So there's less of like an engagement early on with like a trusted provider saying, hey, you know, there's something else going on, maybe you should go to this clinic. So there's less of like a warm handoff that occurs more often for Black and Asian American clients. I already mentioned the sort of involuntary hospitalization rate. And then lastly, folks that are engaged, particularly for Black and Latinx clients, they're more likely to be put on long-acting injectable medications than white clients. And so that's, again, I think that's sort of a double-edged sword, I think. And some would say that, like, some clients would say they prefer to be put on these long-acting drugs because For example, they don't have to think about taking a medication. There's not much to do with like sort of remembering to take these pills. But on the other hand, it's still, again, another choice in treatment that we would make that kind of strips away agency, right? It's just saying, okay, you're going to take this injection and that's it, right? So there's there are less agentic decisions being made for Black and Latinx clients in particular when it comes to medication. All right. So sort of looking at first episode psychosis, once people have kind of had their first episode, the sort of gold standard intervention, and I think we have a few people on the call who work in these clinics, is coordinated specialty care, which is a sort of treatment approach that it's a team-based approach where there's a small staff to client ratio with a few key team members who focus on like family psychoeducation, getting the families involved, or individual therapy, prescribing, and like supportive employment and education. And really what we view coordinated specialty care as like our sort of best tool for addressing outcome, or for addressing this early psychosis and sort of bettering outcomes for folks. However, despite there being strong evidence that coordinated specialty care is really useful in addressing psychotic symptoms, there are some recent analyses of sort of the seminal studies on this that show that there are less benefits for non-white, lower socioeconomic status clients. So, for example, a recent review of the sort of seminal coordinated specialty care study found that when reanalyzing that data, essentially what these researchers did was they came up with a sort of SES composite that included factors such as race, parental occupation, parental involvement, and income. And what they found was that coordinated specialty care, which is our best tool for addressing sort of psychotic symptom, early psychosis, only benefited those in the top 25%. And interestingly, those in the bottom 75% of this SES composite showed little to no benefit from our best tool. So what's really interesting about this is that this shows that even though our tools are essentially meant to be colorblind, there are still other factors, including race, including structural factors such as socioeconomic status and neighborhood characteristics that are influencing outcome for people experiencing early psychosis. Other studies really show differences in terms of Black and Latinx clients' engagement in core services of coordinated specialty care. So, for example, there's Black and Latinx families are less likely to be engaged in family psychoeducation services. And in general, following an index episode of psychosis, Black and Latinx clients engage in less essential services, such as individual therapy and family therapy, than white clients. So what we're seeing here is that our current intervention approach, even though it's our best tool, we're showing different levels of engagement with it. So really what needs to happen is that we need to find ways to engage folks from varying backgrounds in these services with meaningful engagement strategies. So that was a mouthful, to say the least. But that's kind of the sort of state of the literature on sort of early psychosis intervention services and some of the disparities therein. And so what I really am trying to highlight with this sort of brief Ignite talk is that there needs to be much more research to include the voices of like BIPOC consumers and their families on the development of engagement and outreach service efforts. Essentially what happens now is that, and this is a common sort of framework, is that we sort of use this top-down approach. You know, researchers on high are saying, we see this issue, we're going to come up with an engagement strategy and it's going to work for people, right? But what often happens is that we don't engage those communities in developing these tools, right? And so what I would argue is that approach has been used for decades, right? Longer than that, in fact. But I think what needs to happen is that there needs to be a shift more towards more community-based participatory research, getting the sort of viewpoints of community members into the development of tools to better increase engagement in our in care, essentially. Additionally, I think Jody pulled up that frame earlier, sort of looking at all of these different factors such as like sort of institutional, structural, and interpersonal bias and how those impact outcome. And I think that needs to be explored more formally, particularly within psychosis, just because I don't think that's not been formally done as much as it should. And lastly, just looking at factors such as like where clinics are located, which is a structural factor, diagnostic biases, caustic pathways to care, and lack of diversity in the psychosis workforce needs to be addressed systematically. And so this is kind of, parts of this are where my research is sort of headed, and I'm trying to sort of build a program of research around. But I think I really just wanted to highlight with this sort of talk, just the large gaps in literature regarding these areas, I guess.